Guys, after subscribing to this channel, please make sure that you also press the bell icon so that no notification, no new video of mine, any educational video, is missed by anybody.
Then there was a question on medical treatment of acute, severe, abnormal uterine bleeding. So what does that include? We have, first of all, you need to initially assess, stabilize. First of all, if you feel that the patient is hemodynamically unstable, immediately send for cross-match, immediately do her risk assessment, and immediately start the blood and the IV fluids. Involve the multidisciplinary team, the ICU team, involve the blood bank, inform the OT, inform your seniors, okay, involve everybody. Investigations, you need to see what is going wrong, right? So you need to go for a CBC, blood cross-matching coagulation profile, maybe what else? LFTs, maybe for KFTs, and then ultrasound, these basic baseline, of course, rule out pregnancy, very, very important. Then medical management. How will you manage her? So you can give her COCs, but you have to rule out she has no other problem, because now you're giving her high dose COC. You might have to require to give 4 or 6 COC pills in one day. So she should not be a candidate with any thrombophilia or any VT episodes, any family risk of any thrombophilia, or she should not have had any, LFTs deranged or KFTs deranged, especially. And she should not have any metabolic disorders. But, if you're giving it to a young female, which will usually have severe abnormal uterine bleeding, then in that case, these factors are minimal, if at all. So you need to give a pill every 6 to 8 hourly. For 22 days, you give pills like from 6 to 8 hourly. That means either 4 times or 3 times a day. So 3 OCPs in one day, 3 OCPs. Sometimes people give 2 OCPs stat and then BD for 3 days and then OD as usual. And along with that, they give tranexamic acid. Or you can give high dose progestins. That is also a possibility, 10 to 20 milligram orally every 6 to 8 hours. So you can give, 2 progesterone only pills together, and then BD, and continue it. And as you see that the bleeding has stopped or decreased, then you titrate it down. Along with that, you give tranexamic acid also, okay, and mefenamic acid if she's having pain. And in case of refractory cases, the ones who are not having any help with the OCPs and progesterone, then in that case you can give IV conjugated estrogen, but again at a very, very high risk. So be very sure of what you're doing. Otherwise, you'll have to, go in for a uterine tamponade, or, if the bleeding is unresponsive to medications, you'll have to intervene surgically. Now, enumerate any 4 contraindications to endometrial ablation for AUB. You guys know what is endometrial ablation? Anyone who can quickly tell me what is endometrial ablation? Who's going to tell me? Do you guys know what is it? Then in that case, I'll have to tell you what is that first of all, and then I'll proceed forward. If you want me to tell you first, then let me know. That also you will have to tell me. Okay, ma'am, we don't know. I have no issues, but I need my students to talk to me. Okay, it's not a one-way, traffic. It's a class. I want you people to interact with me. I like it when you tell me that, ma'am, we don't know this. I like it when my students are honest with me. You are not my students if you don't know this, right? I am the teacher. You are my students. I will teach you. I do not expect you to know it already. Then what am I doing here anyways, right? So you have to be honest to tell me that, ma'am, we don't know about endometrial ablation completely. Tell us more. Tell us a little bit about what exactly is endometrial ablation. Yes. You're right, Deepika. What we do is exactly that we have certain devices. Now they work on different principles. Okay. We had initially very early on, we had things like the roller ball technique or the transcervical endometrial resection. Okay. These were old ones, the ones which used to work with the hysteroscopy. Nowadays we have the newer ones. Okay. Like NovaSure, ThermaChoice. They are the ones, one of them works with the thermal ballooning method. One of them works with the radio frequency method. One of them works with the microwave endometrial ablation is also there. And then one of them used with cryotherapy. So what you do is you introduce a very small hysteroscopic like device inside. Okay. And then it makes either it goes through a hot water balloon, or it goes through a microwave or a radio frequency ablation, and it just ablates the endometrial lining. But it has its disadvantages, and the disadvantages are here. Any female who wants a future fertility, she's got a desire for future fertility, she should not go for this, because there are no robust studies which tell that the endometrial lining after the endometrial ablation is any day going to be sufficient to sustain a pregnancy. The idea of us ablating endometrial lining is exactly that much, that it does not recur again. So if it is not recurring again, it's never coming to that level at which you will sustain a pregnancy. So desire of future fertility, if it's there, then this is not the method for you. Number one. Then if it's a endometrial pathology already, maybe a polyp or a fibroid or a malignancy, no, not suited, contraindicated. Okay. If there is an acute pelvic infection, again contraindicated. Or if there is a pregnancy already going on, it's contraindicated, right? So these are the 4 contraindications to endometrial ablation. And with this, I finish the class today. Thank you so much. I'm ready for your questions, and I would love to answer my students if you have any. In case you don't have any questions, you can leave the class, and you can, or if you're too shy to ask me the questions, you can always message me in WhatsApp, or you can message me on the channel. I'll be more than happy to help you out. And everybody, if at all you guys are there, the ones I don't see all of them who've just recently passed, please send my message to them that I'm ready for taking the case discussions. If they want any, their practicals are right around the corner. We still have 4 weeks to go, and we can take up the case discussions if they want to. Let me see if I can come up with an OSCE for you in between, so we can discuss the OSCE 2 classes. But once only if I finish with the paper number 4, and then I can take it up. Okay. So I'm waiting for any questions, and then we can wrap up tonight's session.